I start many of my presentations off by saying, I know of a population that's very difficult to communicate with, that is vulnerable, and that needs special consideration. And then I go to the next slide of my presentation and I show the pediatric hospital that is built. I say, look, we recognize that in the pediatric population, and then we care planned around the pediatric population. All of those things I said are transferable to the geriatric population, but we haven't done it yet. And so our program is so unique in that it's not in any way commonplace to have focused surgical care in the elderly. And we didn't even create a separate department to do it. What we did is we created a program that exists in all of the departments, not just the surgical department of orthopedics and urology and vascular and general surgery, but also in the hospital medicine department, in the pre-admission testing department, in the Department of Anesthesiology, in all of these different disciplines are therapies, our physical therapy, occupational therapy, speech language pathology, our social work department. This program exists in all of them now because what it does is it takes the skill set of all of these different areas and it focuses it back toward the patient where everyone gets to bring all their specialty skills. And then as a multidisciplinary group, we then care plan for that frail person so that we can provide, one of the key terms is trying to provide anticipatory care. Rather than reacting after something's happened, we're trying to anticipate what's going to happen and avoid it.
So, okay. So
I'm sorry, I've confused you.
It's a little confusing, but
Yeah, it is.
I have to go through I'm sure usually if I go through and listen to something over again, then I get it, but sometimes I got to listen to it a couple of times. Okay, so let me just take a look at this and sort of frame my next question around that. So it says Clifton Springs Hospital and Clinic and Newark-Wayne Community Hospital have achieved level 1 comprehensive excellence verification status from the Geriatric Surgery Verification Program. And then she says that's a quality program of the American College of Surgeons. It means they're implementing the program's highest standards for older adult surgical patients. What all does that mean, and why is this exciting for us here in the Rochester and Finger Lakes region?
Right. So starting with some definitions in there, the American College of Surgeons is the governing body of surgical care. It's the largest one in North America. And potentially it might be the largest one in the world, but I have to fact check that. And so these governing bodies exist in all of medical disciplines to help guide best practices, to help set standards of care, and provide infrastructure that physicians need to be able to do really high quality care. So the American College of Surgeons has sponsored this program around the care of the elderly in surgical care. And what we had to do was not create the standards of the program that came from the American College of Surgeons. What we had to do locally was figure out how do you actually implement those standards in the care, because you would think that high level communication happens all the time between disciplines of healthcare. However, you go to your doctor and you say, did you know what happened somewhere else in my life? Did you know that I had an operation? Did you know this? Did you know that? And oftentimes the answer is no, right? And so that coordination piece of care is frequently lacking in all of healthcare, whether it's for, young people like yourself or whether it's for the elderly. That coordination piece is lacking. And so what this program does is, number one, it forces the coordination to happen. Number two, it risk screens these patients in things that we traditionally didn't do. It's hard to accept that the standard was to cross your fingers and hope that people would do well. Instead, now what we do is we actually look for their vulnerabilities, meaning how well does their brain function before and after surgery? How independent are they before and after surgery? What sort of support structure do they have? That laundry list of medications that they have, how do they actually interact with each other and cause problems? And what can we get rid of? And so we're doing those tasks based on risk screening these patients, and then care planning for them, again, in an anticipatory way. It means that Unity first, and then Newark and Clifton for the Finger Lakes region has taken on the monumental task of changing the way we care for the elderly.
Awesome. And so do you work at all of those hospitals? Do you sort of rotate?
Yeah, I am on staff at 4 of
Oh,
our
that's fun. That's always
Rochester Regional
fun.
hospitals. And I came out to the Finger Lakes in 2019, right before the pandemic hit, right at the end of 2019, in an administrative capacity for coordinating surgical care for the region for Rochester Regional. And so I left my active clinical practice at Unity, and I started a new clinical practice out in Newark and Clifton in our Geneva office. And so now I'm actively working Newark and Clifton to provide clinical care, but I provide administrative structure at Unity, and we're expanding to Rochester General. And so I go all over.
Awesome. And now, so when you're dealing with someone who I guess is over the age of, I don't know, 75,
Mm-hmm.
As a as an MD, what sort of challenges do you have when working with this population that maybe people just don't know that you would have? Because I can imagine that surgery is different, right? Like the process of surgery, maybe, or maybe I'm wrong, but like, so what do people not know about what's different when caring for and then ultimately performing surgery on someone after you've done all of the screening and sort of this broad scope look at their lives, and you go to do surgery? What things happen that maybe people don't know that can prove to be challenging?
Right. So one of the biggest problems that we have in surgical care of the elderly is not related to the technical aspects of the operation. Because if I take out a colon of a 50-year-old, or if I take out the colon of an 80-year-old, the technical components of that operation are very, very similar. The anatomy is all very similar. One of the biggest challenges we have, though, is in the frequency with which those older adults experience what's called delirium, which is confusion, new confusion that causes them to act and function differently than they would at their baseline. And so we put them through stress of surgery. When you're 40 and 50 years old, you come out the other side of that stress. Usually you handle it pretty well. When you're 70, 80, 90, you come out of that stress, and a high percentage of those patients have a hard time handling that stress in their body, and they exhibit to us what's called delirium, new confusion, postoperative delirium. And so in trying to care for those older adults, the technical aspects of the operation are very, very similar, but the caring for the patient around the time of the operation is tremendously different. We have to focus on the factors that can lead to delirium. We have to, number one, identify those factors in each patient, because they're different for each person. Some of them are medication related. Some of them are lifestyle related. Some of them are nutrition related. Some of them are the simple being able to see and hear us. And then we have to plan for what are we going to do for each of those unique factors in that individual, so that we can try to avoid that confusion.
Gotcha. Is that Is delirium similar to transient global amnesia, or are those two totally different things?
Completely separate. Yep.
So
Yep.
transient global amnesia is like a lap that can affect anybody of any age, right?
Yeah, yeah. Whereas delirium is defined pretty discreetly as the acute confusion. Acute meaning it's happening right now. This is not their normal baseline. This is a change from their baseline. Um, and confusion in that um, they're not uh, processing and responding the way that they ought to. Maybe their attention is different. Maybe their memory is different. Maybe their ability to actually um, speak is affected. And so you see it's complex, a problem that you see predominantly in the elderly.
Gotcha. And so how do you deal with this? And so sort of, obviously that was something that probably got you this kind of recognition,
Hmm.
right? So how do you deal with that?
Yeah, so the first thing that we do is we try to measure the person's risk for developing it, and we try to adjust any of those risk factors to avoid it happening. That's step one. So
Gotcha.
before we do anything to them, we try to measure what's their risk and adjust anything we can. Then step two is we try to ensure that communication pathways are maintained. What the heck does that mean? If I make you take your hearing aids and your glasses off, and then I try to do things to you, you have no ability to hear or see me.
No.
And so your ability to understand what's happening is horrible if you can't hear and see. So we leave the glasses on, we leave the hearing aids in when we bring people into the operating room and when we wake them up. Because if we want them to avoid getting confused, we need them to be able to see and hear us, right? Simple thing like that was
Yeah.
never done before. So right around the time that we do things to people, we have a couple technical things we do, like leave their glasses on, leave their hearing aids in. We also try to avoid using general anesthesia wherever possible. Nerve blocks, regional injections of local anesthetics. Try to avoid those medications that are really hard on the mind.
Yes.
We then bring people out of the operation. We try to avoid giving them medications that have what are called high anticholinergic burdens and medications which are on this very well published list. It's called the Beers list, Beers, Beers list. We avoid using those medications, and you would think that you would naturally avoid using those medications, but they're common things. An example, Benadryl. Benadryl is like a no-go in the elderly. But how many people take Benadryl? Everyone in the world takes Benadryl.
I mean, if I literally was like itchy last night, so I had to take a Benadryl because I was like
Yeah,
my skin itched. So I was like, I don't know, you take a Benadryl.
right.
Yeah.
It feels like I'm taking a vitamin. I'm taking something that's good for me. But there are many medications like Benadryl that are so commonplace that we have to pull back and avoid to try to avoid the confusion, try to avoid the delirium. We then um, implement, or we call them environmental management techniques for delirium. We manage the environment that the person's in. What does that mean? Well, if it's daytime, we make sure that the room is light. We open the blinds. We wake the people up and get them out of their bed to say, this is daytime, you need to be awake, right?
Yes. Yes.
If it's nighttime, we try to cluster the care that we provide to people. If you've ever been in the hospital, you will have experienced the fact that you sleep poorly in the hospital because there are alarm bells, there are noises you're not used to, and there are people in and out of the room constantly. If we interrupt their sleep, then how can we possibly expect them to function well? The elderly have a real hard time if you interrupt their sleep and wake cycle. So, and controlling that environment's important. Also, we put up huge signs on the wall that say, today is Friday, January 27th. Your doctor's name is this. Your nurse's name is this. The tech who is going to take care of you's name is this. It's huge. It's on the wall. so that we can reorient people to the time of day, the place, and what's happening to them.
I mean, it
Uh,
sounds like this is a more, I mean, just in general, the more I'm like wrapping my, it sounds like it's like a much more mindful and compassionate way to approach patient care to this demographic. Like it's just more like compassionate, right? Like you're caring more for that person and their unique needs and situations.
yeah, yeah, and the um, previous decades, 80s, 90s, early 2000s, we focused really heavily on the extra vital sign, the pain vital sign. We were trying, I'm just giving you background. We were trying to eliminate pain as the most compassionate way to care for somebody. Well, the side effect of that, one, is way over prescribing of narcotics, which has led to a nationwide epidemic in drug overdose and unnecessary death, right? That's the younger population. The side effect in the older population is that all of these cultures developed in which we thought it was most compassionate to make sure that grandma was well tucked into bed and had no pain. Well, that's one of the worst things you can do for someone who's trying to recover from an operation is to keep them in bed and completely pain free. What we're trying to do is we're trying to actually help them continue their routines that keep them oriented and keep them functioning well. My father, if you walk into his house, in my parents' house, because they live next door to us, so I do this all the time. If we moved them next door because they need help. And so if you walk in to the house, my father at the same time every single morning is eating a single cup, a measured cup of Cheerios because
No,
it's his routine, because that's how he remembers to eat breakfast because he's struggling with his memory. Okay. So if we help people keep their routines by it's morning time, stay awake. It's time for breakfast. Let us help you sit up. I'm sorry, the lights went out. Sit up and eat. Uh, those are things that actually help them avoid confusion. And so I'm not saying that we don't treat pain, by the way. We definitely do treat pain.
you're not going to like leave people to like
Yeah,
suffer. Yeah.
we definitely do treat pain, and that's actually one of the other pillars of the program is pain control does not mean narcotics.
Yeah.
Pain control includes narcotics, but it doesn't mean only narcotics. It means using all the different types of medications thoughtfully brought together so they don't interact with each other, along with massage, heat, ice, positioning, mobility, getting people to move, they have less pain. And so doing all these things actually improves the outcomes of the elderly.
Well, and the quality of life, right? If
Oh,
you have to have
absolutely.
a
Yeah,
surgery over. So for my last question, I think you did an excellent job. I think, you really explained what this means and why it's important. I guess I have two questions. One would be, how does it feel to be recognized for something good, like we originally talked about? And the second part of that question was, if you could just, what kind of surgeries do you do? Like, what are typical surgeries for you? So we'll
sure.
start with how you feel about the recognition.
Sure. The feeling is outstanding. We are coming through some of the hardest and continuing to be in the hardest years of healthcare in any of our careers, where um, there is so much negative attention to different aspects of healthcare, and the rates of disengagement, burnout, uh, empty positions are tremendously high. And so to be able to launch a program, we launched probably at the worst possible time. It was January of 2020 when I launched this program out here. We started, we stopped. We started, we stopped. We dealt with a pandemic as we were trying to change the way we deliver care at the same time and really bring the healthcare professionals together around this vulnerable population. And what we have done is raise the bar, raise the standard of care in the elderly. And to be the leaders in that, I get to stand up and be recognized by name. But really, this is one of the biggest groups that you can imagine. that participate in this, because it's essentially everybody in the hospital who participates in this. And so for us to rally around a topic that's a positive topic and then be recognized for accomplishment is tremendously helpful in the healthcare environment that we find ourselves in.
Absolutely. I can imagine because it really is. It's everybody from the bottom to the top that has to be involved in this for each patient,
Yeah,
individually.
yeah, absolutely.
So then what kind of surgeries do you typically do? Or do you
Yeah,
have typical surgeries?
yeah. So as a general surgeon, I do a wide breadth of surgery. It includes hernia repair, gallbladder surgery, colon surgery, breast cancer surgery, uh, anything you wind up in the emergency department for related to your organs. So if you have bad appendicitis or you have cholecystitis or your colon perforates or you have a bad abscess somewhere, bad infection somewhere, you meet a general surgeon for that. So that's the type of work that I do. I do both elective operations where you come to see me because you have gallstones and it hurts way after you eat, and we plan to take your gallbladder out, and I do emergency surgery as well when you show up to the emergency department.
Awesome. You did a great job, doctor. Anything else that you would like to add?
Um, I think if you could help me emphasize the team-based nature of this care
Absolutely.
in what you write, that would be very useful, because it's truly not about me. This one's about the care delivery, which involves all of the healthcare professionals that treat these patients.